Well, hello everyone. I'm really excited to be here today, and we're going to continue with the good news. That's our motto here. So I'm Corinne Lewis. I'm a program officer for delivery system reform at the Commonwealth Fund. For those of you not familiar with us, we are a century-plus-year-old national foundation with the overall mission of improving the U.S. healthcare system, particularly for people with low income, people who are uninsured, and people of color. I lead our work on strengthening primary care, do a lot of work on payment reform policy and workforce policy. So really appreciate the conversation we're having today. So like I said, we are going to be talking about ways we can change primary care to better serve patients and physicians and care teams. We have a lot of great experience here. I'm going to introduce our panelists, and then they can tell us more about the great work that they're doing. But first, we have Dr. Sarah Chouinard. She is the Chief Medical Officer of Main Street Health. And prior to joining Main Street, Dr. Chouinard was the Chief Medical Officer of Community Care of West Virginia for 15 years. She's served as national faculty for quality improvement initiatives at CMS and as the medical director for West Virginia's Public Employees Insurance Agency, where she worked on value-based care initiatives. And next we have Jason Ross, the Executive Vice President of Medical Groups at Privia Health. Before joining Privia, Jason was at the Nashville-based health system LifePoint Health. He's also worked for the Advisory Board Company, Blue Cross Blue Shield of Tennessee, and Cigna Health Spring. And lastly, we have Dr. Kirsten Meisinger. She is the director at the Harvard Medical School Center for Primary Care and serves in many roles at the Cambridge Health Alliance and is a national and international expert on the patient-centered medical home. So I hope you enjoy the panel. So we're going to start by asking, what does success in primary care look like, and how are you and your organizations executing on that vision?
Well, it's so nice to be here. Gosh, what a broad question. But, for me, I spent my entire career in a rural community. And hearkening back to the previous conversation, I didn't really go into medical school knowing what I wanted to do. And my medical school did such a good job of convincing us that rural primary care is where it's at. That is absolutely where you can kind of go do the greatest things. And I drank that Kool-Aid and then proceeded to work in that community and now find myself here where what we are focused on at Main Street is serving rural communities. And again, back to sort of, the workforce question, one of the ways we do that is by helping rural practices with care team expansion. I think the real name of the game moving forward is addressing social determinants of health. And frankly, a lot of us did not go to medical school because addressing social determinants of health is something that we really set out to do. But what I know after practicing for years, and any of you who are clinicians know as well, is it's never a lack of understanding about what this patient needs. Get an x-ray, take a drug, see a specialist, whatever those things are. The literature says 40% of the time people are able to follow through on that. That feels high to me. It feels like it's 40 would be kind of optimistic. And so, how do we start thinking about primary care as not only in the office, but the care that we have to provide between the visits? And we're really, I think, getting innovative in thinking about ways to do that with non-clinical staff members, but people who are really kind of held accountable and responsible for ensuring that the social needs are met for these patients, so when they show back up in a primary care office, the chance that the patient was successful in that have increased.
I just saw the first beer get poured, by the way, so kudos to you for doing that, breaking that seal. We're at Fat Bottom Brewery. I usually come here and throw cornhole bags and drink beer, and so thank you for doing that. When I start early, I won't feel guilty. Thanks for the introduction, Corinne. I'm Jason Ross. I work at Privia Health. I've been there for the last 2 years. I think just for us, in answer to your question, our kind of main thrust is the healthcare delivery system in this country works better when you have an independent, vibrant, sustainable primary care and multi-specialty care in private practice, so not employed. So it takes all kinds, but for us, when we kind of look at our data, when we go into the communities that we serve, if that primary care core is being supported in the right way and is vibrant and is healthy, is not burned out, is being paid a fair kind of compensation for the work that they're doing, is being acknowledged as having the right kind of proper total cost of care impact on the populations that they are working with and treating, things tend to go better across quality, cost metrics fairly consistently. Even though the old adage is all healthcare is local and it's different, those kind of basic thrusts generally tend to kind of be consistent across all the geographies. And so our goal is just to continue to help those physicians. One of the things I think we'll probably get into a little bit during the panel today, and it wasn't, I don't think, touched on directly in the previous panel, was some of the things that we're doing for physicians above and beyond just kind of helping them do the stuff that is needed to run their business that they didn't necessarily, is just teaching them to be small business owners and helping to be supportive of that. I mean, at the end of the day, whether you're a 1 or 2 doc shop or a 50 physician multi-specialty group with APPs and everything kind of down to MAs, you're running a small business. And that oftentimes does not get addressed for lots of different reasons. That business needs certain things to be supported. It needs technology. It needs collections acumen. It needs a voice to go negotiate with payers. It needs innovation investment in things as the payment model methodologies change. All these things take time, energy, effort, discipline, money. And so we are there to kind of continue to support physicians there. We feel like that's kind of our little niche in the world. And so we work with about 4,500 doctors across 13 states and hoping to go into each and every state and continue to kind of grow and support independent primary multi-specialty care.
So my name is Kirsten Meisinger. I am only the Director of System Transformation and Leadership at the Center. There is an actual director of the Center. I just want to be very careful to say that in public. Russ Phillips, fabulous guy. So
We fund him, so.
yeah, exactly. So I know you know who he is, but I just wanted to be really just careful to say, I have my wonderful role. So as my inveterate nerd role at the Center, right, because system transformation is, as you guys are hearing, right, it's a lot of attention to detail. It's a lot of really making sure that the system is supporting people. I actually want to go meta because these guys did such a good job giving all of those details. I actually think what success looks like in primary care is joy. When everybody walks into the center and you can feel that the receptionist is happy to see you because they're actually happy to be at work. When you actually have a medical assistant that knows your name, when you have a provider that you know and that you trust, that is actually what success looks like. And that's what I work in. I have absolutely refused to stop seeing patients 50% of the time. I love what I do. I also know because we have to advocate, and I so appreciate the call to advocacy that we heard from the last panel. I don't work more than 50% of the time because I actually feel very strongly that we need to be out there and we need to be making a difference for the next generation, which is, I'm very happy to see this is the theme of the panel. That joy exists. I practice in a joyful practice. We actually have very low turnover of anybody because joy is experienced then also by everybody. It's one of those intangibles, but you know it. You can feel it when you walk in. We need all of our practices to have that joy. Why would you not have that joy, right? We need the nerds, right? Like the three of us to make your practice joyful. And we need a lot of actually coordinated efforts to get there. But ultimately, to me, that's where we're headed.
So I want to, nope. So I want to touch on the point you just made about joy and a lot of the discussion from the earlier panel around this issue of provider burden and burnout. Yalda mentioned, we're losing more providers than we're gaining in primary care, and I think a lot of that can be attributed to just the day-to-day kind of struggles of delivering primary care. So what are you all doing to promote that joy and really promote provider well-being, both at Main Street and Privia, and also just your sort of more specific thoughts on how to do that on the ground?
Yeah, well, Kirsten, you'll appreciate it. I was just in a practice in rural Louisiana, and I was talking to the lead clinician there, great guy, and he said, you know how you bring joy to work? You hire a woman named Joy. And I thought, well, that is depressing. But anyway, it was tongue-in-cheek, but nonetheless. So I think when you start talking about burden or burnout, to me, there are kind of two things that come to the top. So when I was practicing medicine in rural West Virginia, and we had a bunch of providers, and every provider's in a little tiny community that has, under-resourced, tough patient population, et cetera. I think two things are access to information comes up as one, and the other is doing work that is really like you don't need to have a medical degree to do. So, I found myself sometimes, and I don't consider myself to be, terribly precious, but I would find myself on the phone being like, am I the only person who can be on hold for the DME company? Can someone, and the answer was like a lot of times, no, and so there I sat. And it just seems like, such a not a great use of resources. So two of the things that we're really focused on at Main Street is how do we get information into the hands of people who maybe don't have a lot of technology support? We have people on paper charts. I can't believe it. But a lot of people who are still, having a paper chart, older clinicians who are just like, I will wait until I absolutely have to do this or I retire or something. And so when you think about patients moving across the healthcare landscape, if someone could bring me at the point of care, importantly, information about where this patient has been as they've moved across in and out of different care settings, having things like an ADT feed, admission discharge transfer feed, having information, even LabCorp data feed where I know have they had a hemoglobin A1C drawn somewhere else. When you think about value-based care and really lowering costs and increasing efficiency, I think it starts with having access to data. So Main Street has built a data tool that allows clinicians to kind of take a look at what's happened over the last 24 hours and since I've last seen the patient. And it takes a long time because we serve that up on a piece of paper. And people are like, we are very sophisticated. We do not want your piece of paper. And I'm like, okay, we could give you like a portal and you could log in and they're like, well, take a look at your paper. And I'm like, yeah, okay. So what we do is really give this to them in a way that they can quickly look down. I consider it really like a worksheet. What do I need to know? And I'll walk into the exam room. So I think one is don't make me chase information. I mean, I was one of those kind of horrible clinicians who walked out of the room and like screamed for my nurse Jessica, like, Jessica, can you find me this information? And then Jessica's down a rabbit hole and this patient's waiting forever. We can do better than that, right? So we have the tools to do better than that. So I think that's one. The other is, even if you take a typical practice, maybe it has someone working at the front desk and an MA, maybe an LPN, a clinician. Sometimes there's more than that. Maybe there's a community health worker, maybe there's, et cetera. But if you have, 4 or 5 people working there, can we have someone who's really like logistics? And that's this health navigator role that we've created and that we're, supporting practices with. And I think what that boils down to is have somebody else do prior authorizations. Have somebody else other than the care team themselves working on things like being on hold with DME companies or whatever the case may be. So I think back to joy and what would make everybody in my office happy is if nobody had to do those things, which is sort of trying to find information that is readily available, but if you just don't have the system built, and then how to do the hard things that actually do impact outcomes.
I'll try to, I bucketed mine in 2 kind of categories for kind of where we sit in the world. One is very consistent with what Sarah said. The stuff that I would add to that is kind of what I hit on in my first introductory comments. There are a lot of things about running an independent primary care practice, an independent multi-specialty care practice that I don't think people think about when they're like wanting to get out in the world and serve patients and do good. And a lot of it's just not fun. I mean, negotiating with a payer on a fee-for-service fee schedule or some sort of PMPM for care coordination or value-based care payment based on an MLR target, like that stuff's inane. It's hard. Your audience oftentimes is trying to create a situation where it's heads I win as the payer, tails I don't lose as the payer, and that's not fun. Billing and collecting from an insurance company is not fun. Making investments in an EMR is not fun. Trying to figure out how to make my schedule more accessible for patients, online scheduling is not fun. Generally, right? There's some physicians that actually kind of, frankly, we need their input in that stuff. But like when I'm thinking about needing to see whether it's in a very much more kind of conducive practice where I get to see a patient and spend the time I want, or I've got to run 26 to 32 patients a day. All of that stuff that is very important to keeping that small business running sustainably and successfully is acknowledged as being as important, but if I could have a partner who I trust has my back to do that for me so that I can go get to the business of doing what it is that I want to do and what I train for, that's where I feel like for us, we serve that role. And we do attract, in terms of the people that work at Privia, like, we don't mind doing the tough crap. Like that's our job, and we take joy in that. Let us handle that burden so that we can watch you go do what you do, and everybody else is better for the wears. The second thing that I would say, which is a little bit discreet from Sarah's comments, is that the way that we structure ourselves is as a single tax ID medical group. Even though the physicians maintain their independence in their respective communities across the geography, they basically bill through a single tax ID with managed care contracts that are held at that level. So we think like a medical group. Even though our groups can be statewide, nationwide, our physicians at a local, market, and national level, we are very conscientious of making sure that those physicians have a voice and an input. There is self-determination. Self-determination is very, very important when you're an independent practice, right? I want to have a say in how my EMR is configured. I want to have a say in how my schedule looks. I want to have a say in whether or not I think that that payer's metrics is asinine or something that I can actually achieve because it actually provides clinical benefit to the people that I'm treating every day. And so we are very intentional on having physician governance that infuses their leadership. We do not run, we do not make decisions as a company because we think of ourselves as a medical group without physicians' voice being there. And I think the longer that the doctors are working with us in that model, the more they feel like this is real. And you see them light up at our national physician advisory meetings. You see them light up at our national physician kind of technology conference. Like, we're actually making the decisions for this large national company, even though I'm a small two-doc practice in Danville, Virginia. Yes, that's exactly right.
So Jason, what's so interesting about what I'm hearing, and from both your business model and Sarah's, is that what you've innovated is actually what the rest of the world just does for primary care, right? So really what we want to do as primary care is do what we actually train to do, which is take care of patients and embrace that professional joy. And what you've done in very successfully, it sounds like, and I'm thrilled, is allow a business model for small practices. One thing that's, I think, increasingly distressing to many of us that are nerds and study nerd things, right, like giant systems, right, like Yalda, my fellow nerd in arms here, is that this thing called verticalization, right, where primary care essentially gets subsumed by a hospital system. And really what it feels like when you work in a system like that often is that all you're doing is feeding the specialists. And that you're sort of a vehicle, and you're not an actual profession in and of yourself. And it's very interesting to me that in most of the countries that have extraordinarily strong primary care and have invested very deeply in primary care, the business model is a small business model where all of the stuff you just described is taken care of because you don't really have to do much. You just have to go see your patients. And when we do that in primary care, we are the value in primary care. Primary care is the value in all of healthcare. That is what we do, and that is why many of us go into it. I actually fully intended to solve poverty by going into medicine. So kudos to you for being way smarter than I am, Sarah, because it took me a long time to figure out, well, that's a silly way to try to solve poverty. You're actually a doctor. So I did learn, but I had happily then, stayed at what's called the Cambridge Health Alliance, which is a safety net hospital system, but it's a rarity in that it really has enabled primary care to be the dominant driver, not just financially, but culturally of our system. And that's it's very unusual. We're an absolute unicorn. Don't recommend anyone try to follow this path because there's only one unicorn usually, and they're always endangered. So what we do want to do is we want to follow the path that I think you guys are outlining. We do want to go, in my opinion, this is the world according to Kirsten people, sorry, but you gave me a platform. We want to go back to the community-based practices, right? How powerful is it, right, that an Elvis shirt actually allows you to take care of someone? We have to do that, right? I've actually learned the languages of the patients that walked into my office. I can do that, though. I'm a weirdo. Most people can't just learn a language. But all of the doctors and the PAs and the NPs that I work with have incredible investment in the communities that we serve. They've bothered to learn the culture. They understand the language enough to say hello and a few things and then go, wait, no, interpreter. We have interpreters available, right? I work in a very highly diverse environment in Boston. The important part, the value in healthcare is giving patients help when they need it. And we are the front door, right? We also, we have to maintain that status. And that's the how is going to be, give us back our power. And maybe no one's gonna give it to us, guys, right? Maybe we need to take back our power. And I think that's what we're starting in this series of conversations.
I love that. I feel like across all of your answers, a few themes of teams, it's technology, and it's really using those things to give providers time with patients again, which is why, they go into primary care. And in my biased opinion, I think value-based care is sort of a vehicle that can support all of those aspects of care delivery. So I'm curious to hear, I know all of you have worked on value-based care in your current roles and previous roles. There's a huge momentum now, both at the federal and state level and in the private sector, to move towards more value-based care for primary care providers. What have you seen being a part of those transitions on the ground, and how it's improving care or not?
Yeah, so, we are a value-based care company, and it's fun for me to be the chief medical officer because while people like Jason are thinking about contracting, and, MLR targets and whatnot, I get to kind of think about, well, what does it mean as a clinician? And when I think about why is value-based care attractive, it is the way it might feel to be an outpatient clinician. And if I, instead of walking into any given day and kind of literally feel like I'm looking down the barrel of a gun of how am I going to get to 5 o'clock or 6 o'clock because of so many patients who are on the schedule, plus the number of people who I want to squeeze in because they need a walk-in visit, who I might not even hear about. They're not even going to ask me, right? They're just going to say she can't see another person, and then this patient who I would have chosen to see is not even on the schedule, et cetera. But getting away from fee-for-service, where we are, incentivized based on volume of widgets of activity in any given day, I cannot run away from that fast enough. And so if instead, listen, I gave a talk yesterday in San Antonio talking to a bunch of rural health clinics, and they were saying, how do you get providers to get excited about value-based care? Well, it is not through ICD-10 coding, right? CPT coding, that's titillating. No one is interested in doing this, but we got clinicians interested in understanding, well, I need a certain number of bullets in my review of systems in order to charge a certain CPT code, right? It's kind of back to your point of the business of medicine. We understand as clinicians there are certain things that we have to do in order to, create value, economic value for the clinic. Well, to me, if what I have to do is get clearer and more specific on my ICD-10 codes, make sure that I'm documenting things like if I've done, a med reconciliation after a patient's discharged from a hospital, if what that means is that in some near future world, my patients can be not risk adjusted, but risk stratified, and I know who the top sickest 10% are, and those patients can come in every day, every week, once a month for an hour, for 2 hours. I can have a care team that's really working on their, real problems, which are probably also, psychosocial problems. And instead of getting 15 minutes, you want to talk about equity. To me, the system is built, it's anti-equity because it doesn't matter what you have, whether it's a hangnail or 7 chronic conditions and you're a hospital follow-up, it's, a 15-minute office visit. Now, not everywhere. A lot of people have done better than that, but in a lot of places, that's still the case. So I think what value-based care offers for hope for clinicians is a different feel through scheduling. Kirsten and I have been on panels and discussions together that there are innovations, but I'm talking about what is the typical experience for most outpatient primary care practices today. And it's they walk in and they have 15 or 20-minute office visits, and it's not risk stratified, and it's not paying attention to sort of, whoever has the most need gets the most time, et cetera. And so if value-based care, if today getting really clear on, my documentation inside my chart, making sure that quality measures are addressed, if all of this is a path to that world, sign me up, because that is the world in which I would really want to practice medicine.
So I'm really glad this is a small room, and I'm really glad there's not a lot of my colleagues in here, because I'm going to say something that feels probably a little heretical to a lot of what we talk about when we talk about value-based care. I have thought about this topic a lot. I ran health plan-owned patient-centered medical homes in 2009, worked for LifePoint for 8 years. You've referred to yourself as a nerd. If I were to call myself a nerd in one area, it is trying to figure out how payment drives the right outcome, the right behavior, both from a kind of a cost macroeconomic. At Privia, a big, huge part of our emphasis with our primary care doctors that we support is helping them to succeed in alternative payment models as they are structured today. Where I struggle is, as they're structured today, they suck. They're not sustainable. We get criticized a lot of times from our own physicians. We're not moving fast enough into risk-based contracts. And our response with disciplined restraint is because that contract is structured to make you lose. And we are not, and because we're sharing the risk with you, we lose when you lose, we're not going to let you do that. And here's why. And so we've been talking about value-based care in some sort of iteration for decades, and it's had a lot of different names. And as we sit here in 2024, I'd like to see one hand raise if they have more than 15% of their top line revenue or 20% of their EBITDA created through a value-based care reimbursement model. It ain't happening. You, okay, great, terrific.
Massachusetts.
Terrific, 1 out of 50.
Medicaid, Massachusetts.
1 out of 50 states, we're getting there, right? Like that's 2% of the states. So part of me is like, okay, if I'm trying to be pragmatic and I'm gonna accept the way that life in the world is there a fee schedule? Is there a fee-for-service fee schedule? Because when you hear about abuses of the fee-for-service rat wheel, a lot of times they're not talking about primary care. They're talking about every other specialty where the economics are a little bit more perverse and a little bit more tantalizing to go abuse that. Can you actually figure out a fee-for-service productivity that allows people to see more and more patients at a volume that feels sustainable, that creates conditions where joy can be realized, where physicians are getting paid in a model that feels very consistent, and just stop talking about alternative payment models that are really structured for payers to win. They're the house in this game. And if you all gamble, you know Vegas doesn't exist because they lose more than they win.
So the concept of value-based care, right, is a very simple one if you think about it, right? Just going, again, I feel like my job is just to be like, whoo, it's dangerous down here, and I go, whoop, right? You guys are fighting the good fight, and I get to say platitudes, but I'm also still seeing patients, so it's all good. Value-based care is very simple, right? The concept that you're actually getting something for what you pay for. That makes a lot of sense, doesn't it, right? It does beg the question why we thought we were just going to pay for healthcare and get nothing out of it for a long time, which is exactly what we're doing, right? We pay a ridiculous amount in this country, and we get extraordinarily poor results. And we in the United States have an amazing series of healthcare systems, right? Because there's like hundreds of thousands of healthcare systems in this country, not one. And we actually have terrible health outcomes. And that doesn't mean that we don't have good systems. It means that something else is wrong, right? The actual work that people are doing isn't bad work. It's that we are paying for the wrong things. We're not getting value for the money we're paying. I worry that value-based care, the way I've always said what you just said, Jason, is that value-based care feels to me like the new dropsy. So like the clinicians kind of know what I'm talking about, right? Like dropsy is this thing where they're like, I don't know, he fell down. And it turns out later, right, like with, CTs, MRIs, lab tests, you're like, oh, it's like 18 different diagnoses, right? It's CHF, it's seizures, right? It's that she's got conversion disorder. There's all sorts of these funny, like completely unrelated things, but all you saw was like, oh, he fell down. This is what value-based care feels like to me, right? If you put anything that's not straight fee-for-service together, we call it value-based care. I think what we want to do is back that up, very much like I think both of you have talked about, get back to what Sarah was talking about, which is I need to spend more time with people who are sicker. This is not rocket science, guys. Also, primary care is one of the only specialties asterisk neuropsychiatry, right? Because when you really need a psychiatrist, you really do need psychiatry. We are the only specialty where more is actually more value. Like, we are the specialty where more is better. More visits with us make you healthier. No other specialty can say that. So we are the value in healthcare. That's why I keep saying it, because it's actually a nerd fact. Oh, nerd fact. I'm so excited. I keep forgetting to say this. We don't actually have to pay that much attention to how we're billing anymore. We just have to use time-based billing. We have been freed, people. Please process what I'm saying and change your behavior tomorrow. You can bill based on time now. Sarah and I were in the room when CMS decided this, and nobody's using it. So honestly, guys, the cage door is open. You're sitting in the cage going, when am I gonna get let out of the cage? The door is open. Walk out into the sunshine. Please use time-based billing. Please stop counting review of systems. Stop paying attention to the note and start paying attention to the person. Take care of people and everything will be fine. You can't say that for other specialties. Although largely it's true. We are the value in healthcare, and we have the tools increasingly to be able to show how valuable we are, but we also have to use them, right? I say this because people in my system are making me crazy. I keep telling them, just do time-based billing. By the time you figure out how many review of systems you need, you've already achieved the length of time for a level 5 visit. So just do the level 5 visit in the first place, right?
Or better yet, don't have level 5 visits.
We will get there. We will get there. The promised land is coming.
I love ending on that. I love ending on that note. So value-based care, lots of potential, but work to do. I completely agree. So I want to talk a little bit more about shifting gears, trust, and how we build trust with communities. I'm especially interested in hearing how Main Street approaches this from the rural standpoint, but all of your perspectives on how we can really think about building trust with communities and the providers that are in them.
Yeah, oh my gosh. So last year I went to 26 states. Yeah, I have a lot of miles collected here. And, you know, not only that, but went to 26 states that are places that, you know, I've never even heard of before. Because we really are partnering with people in sort of the nooks and the crannies of our country. And guess what? I wouldn't respond to my email. I wouldn't pick up my phone call. And so we go and knock on doors, and it is 100% relationship based. And we have to sit down and, you know, I only know rural people. You know, I really, yeah, my brother lives in Manhattan, and he's sort of he's the black sheep. And the rest of us have just been wandering around in these communities for a long time. And at the end of the day, people want to decide if they like you before they decide what you have to say is interesting or not. And so I always say to the, you know, to my field staff, you know, the first meeting is just for them to check you out. They've heard nothing that you've said, and in plan meeting too, because then they're actually going to hear what you are interested in partnering on. So I think for us, it's been super expensive, it's been super hard, it's been super tiring, but we've been really successful, and it is because we, first of all, are super picky about who we hire. I was just talking to somebody who's here about one of our clinicians in Texas. I mean, you can't come up with a nicer, more genuine person who believes in the mission. And so, you know, someone once said to me, and I was so insulted, they said, gosh, you're really good at pitching your business. I said, pitching? I've never pitched in my life. You know, just going out and talking about it. It's like, do you pitch when you're talking about your kid? You know, it's like, well, let me tell you about Will. Will is a 21-year-old. You know, right? And so it's just talking about what we're doing, and we're all excited about what we're doing. So I think the trust piece is breaking it down, and based on what, you know, both of my colleagues up here have said, we don't ever go in and talk about, you know, the importance of, you know, contracting with Humana. We don't ever go in and talk about, you know, all of the nuances about alternative payment models. But what we say is there's a lot happening, and figuring that out is super challenging. And what we really see ourselves as is like embedded technical assistance, and technical meaning patient-facing, you know, that we're really helping the patients figure out the mechanics of, I mean, who could understand? I mean, my dad is an attorney, and he called me and he's like, is there any shot you could help me with Medicare enrollment? I'm like, no, no. no shot. So, really having people who can talk to patients a little bit about, here are the differences and here's what you need to know, et cetera. So I think for us, it's just person by person, patient by patient, and that is arduous, and it's not quick, and it's not slick, and it doesn't have, any kind of quick win, and it's been just well worth all of the miles.
Sarah, if your dad needs help, just tell him to call me. I can help him.
Okay, good, I will.
Kidding. I mean, again, I think I would start with the basic kind of psychological trust is earned, not given. Trust takes time. And so, which I think to me underpins a lot of the things as to why, companies that are trying to make things better are not growing faster, because inherently, if you're trying to fix broken stuff or help support a group of physicians who historically feel as though kind of the system is fixed against them, they're looking at you with the appropriate jaundiced eye, right? Like, who the hell are you, and how are you going to try to squeeze an extra 2 cents out of my back pocket when I'm not looking? And that is a very kind of obvious and not surprising place that we start with a lot of doctors. I think that in practices in general, office managers. And so to us, it's a very simple, if we can get that meeting that Sarah talked about to talk, it's really just like, can you tell us what you think is really kind of impeding you from continuing to practice in a way that is financially sustainable and helps you create that joyful experience where you want to come back and work and feel renewed every day? The thing that I would tout about our model is that we are not just focused on Medicare or Medicare Advantage. We are not just focused on value-based care. We're focused on all payers, all reimbursement types, all patient types, technology, services. So we're trying to understand them as a physician, as a leader of their practice, as a small business owner. And we have these parts to our solution that say, look, if you come on board, here's how we think we're going to make an impact to you in the first 30 days. Here's how we think you're going to feel a difference in 180 days. Here's how we think in 365 days how you'll really feel different. And they're all discrete. They're related, but they're discrete and they're cumulative, and they start to build on one another. So for us, it's very simple. It's like, make these commitments to them and honor the commitments. And don't pitch. Don't sell. Just say, this is what we think we're going to do. We're not perfect. We screw up. And when we screw up, we do our damn dead level best to make amends. And so to us, and so when that happens, and then it's working for us in some of the most mature markets that we're operating in, is when the physicians are out there who are part of the group, the Privia Medical group, talking to their colleagues who are not about this is what happened. And so, but it is a long, difficult process. And I wish you could accelerate it, but I think the question is beautiful, Corinne, because ultimately, if you do not have trust in the people that you're trying to work with, you have not a snowball's chance in hell of succeeding. And that trust takes a long time to earn, and boy, it can be lost in a heartbeat.
So your relationships really are with providers. My relationships are still primarily with patients. And so what I would say is, one of the most important things that I have done and have never stopped doing, because honestly, I got my butt handed to me the first time I didn't do it and thought, well, I'm never going to do that again. At least I learn, is integrating patients onto our care teams. So we don't know what we don't know in the healthcare system. What I will say is I don't know a doctor who uses the regular care pathways to get care for themselves, because they're so awful that you just call your friends, right? It's so hard to sign up your dad for Medicare. I tried, I cried, I called a social worker, right? You actually have to talk to Jason to get your dad signed up for healthcare. We have failed so completely that we don't even use the systems that we build. So what I realized is, I certainly am not gonna know how to do a refill workflow that's going to work for patients, because I do my own refills, right? This is why doctors die earlier than we should. This is all bad, guys. I'm just saying that this is what we do. If you start to put patients next to you as you design the care, they'll just show you the things that you missed. And it's actually extremely efficient. It's a little intimidating. I think patients are extremely predisposed to want to help us. And I think fundamentally doctors are afraid of patients, particularly more than I'd say other providers. And I think it's because we're always worried that they're going to ask us for something, and we're just tired of being asked for things because we're largely a lot of burnt out. Like for a very long time, none of the doctors I worked with would walk through the waiting room when they come to work because they were afraid they'd get stopped by someone. And I think there's that fear of like just the overwhelming need that we have, particularly in primary care. That genuinely has gone away now. I mean, people walk through the waiting room all the time now, and they know that that person's going to get help today because we have a team, and because one of the most important members of our team is a patient, and our patient is actually guiding us in the places that we have missed. And so I would say if I was going to, the way to connect with community is way more complicated than that, and we actually have an entire community health department at CHA, and I work in that space as well. But I would say to family docs, getting a patient on your leadership team, probably two, so that they don't feel like the weight of the world is on their shoulders, is probably one of the simplest way to actually become a more efficient practice.
Fabulous. So I have one last question, and I think we're going to take a few minutes for audience questions, if you think about that while we're hearing the final answer here. But there's so many great lessons and ideas that you all have shared about what it really will take to innovate and improve primary care. I have a really hard question for the end, which is if you had one sort of big picture wish that's really the key for how we're going to scale and sustain effective models like the ones that you all are a part of, what would it be?
Gosh, one wish. I think that for me, it kind of touches on what Jason was saying he thinks is a dirty little secret, which is that, all of the advanced payment models, all that we have, all of this healthcare contracting, where we are right now, it isn't the answer. But what I do think is important is it is a requisite step to getting to what I would consider, really a panacea. And so my one wish would be that rural patients could experience the same quality of healthcare that you can get in any other setting, be it, suburban, urban, et cetera. I was once in a large conference room. It was a legislative thing in West Virginia, and a really bright guy, also an attorney, was listening to all of the quality outcomes that we had at our health clinic. And I'm proud to say that on our UDS measures that we submit every year as part of one of the requirements from HRSA, it was maybe 3 or 4 years ago when I was still at the health center, we had the highest quality in the 5 most rural states in the country. So, this is something we're really proud of, really worked hard on. And this guy leaned over to me and he said, Sarah, let me ask you a question. I said, what is it? And he said, how would a guy like me sit in your waiting room? I didn't even get it. I'm like, well, I guess you just walk in and sit in the chair. And what he meant is you're serving all disadvantaged. You've got 50% of your patients who are greater than 200% below the federal poverty level. I'm not going to fit in your clinic. And it just struck me as so interesting that kind of going back to it goes both ways when you talk about sort of, the importance of feeling comfortable in a culture that you're in. So I think my wish would be that there is sort of a level playing field as it relates to resources for primary care, access to specialty services, and most importantly, that patients know that when they go through the door of a primary care center, especially in a rural community, that they're getting the best of the best. Because those people are out there. The people that I practiced medicine with for years and years and years are great doctors. It is that the system is so convoluted and so tough, and the incentives are so malaligned for high performance that you get bogged down. The fact that provider burnout is the front page of journals for months and months and months is just such a sad thing to me. And so I think that it's never let a good crisis go to waste. And so, if we are in this era of trying to figure out what is value-based care, I'm going to glob on and say, heck yeah, let's use this as this opportunity to create that world. Yes, for clinicians, but really for rural people.
I would say I am very interested in, but not involved in issues of policy. And I and the reason why I think I'm interested in is because I'm a patient person. I don't think you can work in healthcare and not be a patient person. Maybe you can be patiently impatient about stuff when you want things to change, but I am inherently a patient person. Good policy implemented takes a long time to take root. right? And so I'm just busy trying to work within the confines of today. But if I had a wish, one of the I forget the panelists before us sitting in your seat said it beautifully. When she graduated from medical school, she was probably top of her class, and she was going into internal medicine, and everybody loved, like, that's what you do. I have been working in healthcare long enough where those 65-year-old internal medicine physicians that graduated top of their class, board certified medicine, went practice primary care. That does not happen today for lots of reasons that we've all touched upon. Part of it is reimbursement. Part of it is that social network around them tells them that that's not the right thing to do, which to me is tragic. If I had a wish, shut those voices up, pay these people what they're worth, create policies that incent that behavior, and have the patience to let it germinate. And you will bring the brightest, you will bring the numbers back, we will reinvigorate primary care. And so our little world of, I love the policy, what I'm trying to do now is have the 4,300 doctors that are part of Privia, a big chunk of which, 65% of which are primary care, family practice and internal medicine, OBGYN, peds, talking to other people inside of residency programs that are young out of practice, say, you can make a damn good living in this model with good quality of life, experiencing joy. There's ways to do it. It doesn't have to be with Privia, but there are ways to do it. Like, give it a shot, right? So we're trying to do it in our little corner of the world. But from a policy perspective, I think to me, that is what I would wish for.
It was technically 3 wishes, but we can just make it a
listen.
genie. It's all good.
You were counting.
I was listening to you. This is a wonderful. I'm enjoying myself tremendously learning to you two, learning from you two. So my wish would be that every single person in the United States has a doctor, nurse, patient navigator team working together, either within walkable distance or 10 minutes drive from where they live.
Simple. Far more simple than mine.
Small stuff.
I think my wish has to be realized for that wish to be kind of realized as
Jason,
well.
all I
Don't
have to
think?
tell you, my friend, is this is why I said I wanted to go last. Because you did all the
She
work.
had the last
And then I
word.
was like, what he's actually saying.
I
So
tried
next
to get
panel,
the seat.
you're going to have
All
to get the
right,
last.
I will.
I'll give it up.
I'll arm wrestle for you.
Do we have time for audience questions? First question was, how fast does the money have to flow to make value-based care work? And the second question was, how long should evaluation time periods be?
I'll let Jason wear the dark hat and talk about money in more detail. But I do believe that the money has to flow. So how fast does it have to flow? I really don't know. But the way that we built our model is that we are paying practices upfront as opposed to a model in which they're waiting on shared savings. I think it's a non-starter. So it made me crazy when I was in the practice. I met with every single person who would possibly take a meeting with me to try to squeeze every nickel I could squeeze out for the health center. So if someone came around for a P for Q, or we joined an ACO, we did everything you could dream up. And typically what happened is I would have a health plan come in and say, hey, if you can do A, B, and C, then there's going to be this big amount of money that you could possibly achieve at the end of the year. And I'd say, great. And we would get a line to do it, and I'd put a team into place. We had a quality team, et cetera. And then the end of the year would come and they would say, oh, you were supposed to do 377 mammograms. You did 362 mammograms, so you didn't meet that measure. All right, let's go to the next one. And it would be this gigantic number of patients that we had served, and we were X% shy of meeting the measure. And the answer was here's 3 cents and we'll see you later. And it made me furious. And so what I would say is how about we don't try? Right? We would never do that because of human beings. But what if we actually weren't putting that effort in? And so it struck me in helping build this business that there needs to be money up front and sort of back to trust, trusting our practice partners to say, we know that you are going to do this work. We know that you are oriented. This is what family doctors do. We know you're oriented to wanting to drive quality, that you want patients to come back in. Not only that, we're going to give you this person to help kind of facilitate that process. So I think the money has to be be achievable, first of all. You have to be able to achieve it. Maybe it doesn't have to be, whole hog, but there has to be something on the table, and I think it has to be quick. It's just like any of us in life. I mean, if you want to wait 10 years to see something, you lose interest pretty quickly. So I think it has to be quick is the answer. And then the second part of the question was?
Evaluation time
Yeah.
frames.
So had this conversation yesterday, talking with someone. When you look at, for instance, just HEDIS measures, look at patient behavior. Look at our own behaviors as patients. These metrics don't turn quickly. And so I think like the very soonest you could see anything as it relates to really, changing behavior is like 36 months. I mean, I think it's going to be a long time before you can start to see, gosh, ER utilization patterns change, patients understanding the importance of following up after discharge, improving hemoglobin A1Cs, whatever those are, whether they're process measure or outcome measures. It just takes time for both the practices to have behavior change and the patients to understand their engagement and involvement in making those changes.
Listen, I think it's two great questions, and I'm definitely I'm sensitive to how hard it is to pay for the right outcomes. I would say I'll just kind of use my most recent experience at Privia. We've got in excess of 100 value-based care contracts across commercial, Medicare Advantage, managed Medicaid, and then we have a lot of physicians with a lot of lives in the MSSP program that is in an enhanced track that's got some significant downside. We do not insulate the doctors from the downside. Again, that's why we're trying to be very judicious on which ones we go in. I think the contracts that we have seen work the best have a blend where you have something coming to the doctors in an upfront that's helping with cash flow. Basically, again, go back to the small business. I need cash flow. I'm seeing patients. I've got a revenue cycle that turns claims into cash from 14 to 39 days, depending on who the payer is. But if I'm in a value-based care arrangement that's got alternative payment modalities, it'd be nice to see something that comes through on a quarterly basis, on a semi-annual basis, with some sort of kind of lump sum on kind of whatever that annual true up is. I would differ a little bit. For me, the answer to part two of your question is I think it really depends on what they're getting paid for. Because there's so much churn in the patient populations for the carriers, it's impossible to go to 36 months. You'll have a fraction of the patient in the denominator after 3 years that you had when you first started because of so much churn, unless it's fee-for-service Medicare where you've got a much more stable, although a lot of those folks are starting to move into MA at kind of an increasing velocity, right? So, but if you're talking about a pay-for-process metric, did that patient get those evidence-based standards of care? A year, right? If it's I'm trying to figure out the number needed to treat to reduce ER fall or ERK or some sort of kind of more traditional health plan metric. Those are really hard because of the churn in the underlying populations. And so honestly, respectfully, I don't have a good, there's not a payer that has the longitudinal interest in a stable population that says, I'm going to pay you for a 5-year, a 7-year, a 3-year outcome. It will never happen.
So this is where I'm going to differ pretty dramatically. This may not be helpful. I find it helpful, but I'm, a nerd, as we said. So the ultimate outcome is death, right? Your alternative is you're alive. Hopefully what we really are aiming for is health. Those are actually hard to define, not the death part. That part's easy. One of the things I think we want to think about in terms of outcomes is, are we trying to design a healthcare system for health, or are we trying to design a healthcare system for profit? And in this country, we haven't designed a healthcare system for health. We have designed a healthcare system that makes money, and if health happens, that's lovely, but that's a side effect. And that is the big miss, guys. That is why we are spending more money than anyone and getting very little value, because we are focused on the wrong thing. We should not be focused on the money, we should be focused on the patients. And we've already shown that primary care is the value in healthcare, so there should be a trusting relationship with the funders, who ultimately really is the government, if you want to do the complex work of how much taxes companies paid, blah, 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 right? But we have chosen an employer-based healthcare model increasingly that's unsustainable. More and more people are going to be getting care at community health centers, and more people are qualifying for Medicaid. And even if they don't qualify for Medicaid, they probably should be getting Medicaid, because no one is getting care because you can't afford the deductible, right? These healthcare plans are squeezing people harder and harder to make money. And I don't think we want to fall into that rabbit hole. I think we want to jump out of the rabbit hole and say, what are we really after, right? Does the AFP stand for health, or are we going to focus on healthcare? I think we want to focus on health. We can do that as primary care. It's a tougher sell if you're a neurosurgeon. Although if you need a neurosurgeon, you really need a neurosurgeon, I have to say. I'm a big fan of neurosurgeons when you need them. So the dispute in my mind is we have attributed money in our healthcare system to the wrong place, right? We're giving it to specialists and procedures. We're paying attention to where the money flows and not whether we're making better health. I would love us to get competitive about who has the healthiest patients, who's had the biggest differential in their health outcomes, who's had the lowest number of deaths in their patient population in the past 10 years in their county. Because again, my dream is to have it be based where the patients are, not make the patients travel. So I'm very pie in the sky, and I don't know if that's an unhelpful, Sean, way to end this, but I do think we have to ask some very difficult questions of ourselves, and I do think we have to probably be honest about having kind of missed the boat on our healthcare system and make some very courageous changes. But we're primary care. We're the ones that are going to, I want to say benefit, because it's not like more work is a benefit, is it? But we need to be able to do the work, and we need to be able to have more of us to do the work that really matters to people, and then we will save money. It's all going to be a virtuous cycle, but it really isn't right now, and I think that's part of why we're all having so much trouble.
Well, I think that's a great note to end on. I want to thank you all both for the work you're doing every day and also for this conversation, actionable solutions and big ideas, so a lot of optimism. But please join me in thanking our panelists.